Hi there. Thank you for joining me for the fourth session of the medical assessment of impairment. My name is Roger Pillemer and I'm an orthopaedic surgeon with a particular interest in impairment assessment. What I would like to do in these sessions is give you some examples of the sorts of medical impairment issues that we have been discussing at our regular meetings over the last 13 years or so. As mentioned previously, my intention is to present one session each month to be uploaded on the first Friday of each month. Now, at the end of my last session, one of the questions asked was, can one have a flexion contracture and an extension lag in the same patient? Firstly, just to go over the clinical differences between the two conditions. The patient is asked to elevate the leg with the following result. Now, if there is any quadriceps weakness or lengthening, the patient is unable to actively fully extend the knee because of loss of power, that is, extension lag. On the other hand, if there is tightness of the posterior capsule, for example, then there is a mechanical block to extension, that is, flexion contracture. Remember, flexion contracture actually means loss of extension. If then the examiner passively attempts to extend the knee and it does extend, this is extension lag. If the knee fails to extend passively, that is flexion contracture. The patient is asked to lift the leg with the following outcome. If one then tries to extend the knee and there is no movement, then that is due to a flexion contracture. Even if there was an underlying extension lag, it would not be detectable. However, if the extension lag is greater than the flexion contracture, the knee will in fact extend until one reaches the restriction due to the flexion contracture, as will be shown in the video. Here one can see the original starting point, with the knee then passively extending due to the extension lag, but stopping at the point of flexion contracture. So in summary then, one can detect both the flexion contracture and an extension lag in the same patient if the extension lag is greater than the flexion contracture, but not the other way around. The second question then was, can you suggest two physical signs that would help you distinguish between an L5 nerve root lesion and a common peroneal nerve lesion? Well, here is the problem. This slide shows the sensory distribution of the common peroneal nerve over the lateral aspect of the leg and onto the dorsum of the foot. Here is the distribution of the L5 nerve root, virtually the same as the common peroneal nerve. With regard to motor power, both conditions can present with a dropped foot. A clue to the answers must be something or some things that the L5 nerve root supplies above the knee, that is, above the origin of the common peroneal nerve. Well, here is one answer. Abduction of the hip is supplied by the superior gluteal nerve derived from L4 and L5 nerve roots, so that with an L5 nerve root lesion, one can get weak abduction of the hip. And the second differentiation is once again the medial hamstring reflex, which is supplied by the L5 nerve root and is not affected by a common peroneal nerve lesion. What I would like to discuss today is how to differentiate between a high median nerve lesion and a low median nerve lesion. Every now and then, one comes across a patient who has had a carpal tunnel release, and post-operation the symptoms remain unchanged, and if the first operation was done percutaneously, the patient will often undergo an open procedure, once again with no improvement. I've seen a couple of cases now, and others I've probably missed over the years, where this has occurred, and it behoves us to at least be aware of the possibility that one may be dealing with a high median nerve lesion. I would like to suggest three physical signs that can distinguish between these two conditions and help to avoid confusion. Firstly, with regard to sensation, as one can see from this slide taken from Netta's wonderful book of clinical anatomy drawings, the palmar cutaneous branch of the median nerve comes off above the palmar carpal ligament and is therefore not involved in a case of median nerve compression within the carpal tunnel. So, with a high median nerve lesion, there will be sensory loss in the palm of the hand, whereas the palm is spared in a low lesion. This slide shows the area of sensory loss in a high lesion, which is spared in a low lesion. In considering the motor supply of the median nerve, it supplies the flexor digitorum profundus tendons to the index and middle fingers, as well as supplying flexor pollicis longus to the thumb. The muscle belly of flexor digitorum profundus often only splits into individual tendons low down in the forearm, resulting in group action of the flexor tendons to the fingers. You can tell in your own hand whether the profundus tendon to the index finger is independent by fully flexing the medial 3 digits and seeing what happens to your index finger. When I do this, my index finger also flexes slightly, so it is not fully independent. The only truly independent flexor, therefore, is flexor pollicis longus. The third sign is that percussion over the upper mid-forearm, where the median nerve passes under the fibrous arch of flexor digitorum superficialis and can be compressed here. One will be able to elicit a positive Tinel sign in this region. This slide, again from Netter's book, shows the median nerve passing under the fibrous arch of flexor digitorum superficialis. So, the 3 clinical signs to look for in a high lesion are, firstly, sensory loss in the palm in a high median nerve lesion and sparing in a carpal tunnel lesion. Secondly, diminished power of resistance to flexion of the IP joint of the thumb. And thirdly, a positive Tinel sign in the upper mid-forearm. I'm going to show you a video of a man who is a spray painter and sustained compound fractures of his forearm bones which were successfully plated. He developed median nerve symptoms and eventually came to an open carpal tunnel release with no improvement in his symptoms. At the time I saw him, he'd been back at work for over a year and was coping, but with a lot of difficulty and with ongoing median nerve symptoms. His main concern of his work was that whenever he tried to spray paint at a low level using his injured dominant right hand, he would lose control of the spray gun. He therefore did all his low spray painting with his left hand. Here you can see the well-ingrained hands of a manual labourer, and note how relatively easy it is to overcome flexor pollicis longus, and in this instance also flexor digitorum profundus to the index finger. While on the normal non-dominant left hand it was not possible to overcome flexor pollicis longus without fear of snapping the tendon, and also note that flexor digitorum profundus to the index finger is very strong. And a positive Tinel sign in the upper mid-forearm, probably in this case related to the original injury or the surgery rather than the fibrous arch. Once again, before we end, let me suggest 2 things to think about before the next session. Firstly, this is the deformity in an ulnar claw hand with extension at the level of the MP joints of the ring and little fingers and flexion of the PIP and DIP joints of these 2 fingers. Can you explain the mechanism and the principles underlying this deformity? There is a really interesting and satisfying explanation. Secondly, what is meant by the term ulnar paradox? By the way, talking about deformities, this is known as the boutonniere deformity, which is French for buttonhole. What happens is that when the attachment of the central slip of the extensor tendon to the middle phalanx ruptures, the PIP joint buttonholes through the 2 lateral slips of the tendon. That is a boutonniere deformity. You know, of course, what the French call this deformity, la buttonhole. Once again, thank you for your attention, and I hope you found this talk useful. I also hope that you'll join me again in a month's time, and until then, Salani Gashli.